Hi, I'm Dr. Joanne Smith.
And I'm Dr. Corinna Hankins.
And this is A Pod Full of Pediatrics. Subscribe here for more content.
Or go to onecommunityhealth.org.
Or follow us on social media at One Community Gorge. And this is the one where we talk about HPV and meningococcal vaccines.
And that's really hard to say.
It is. It's a lot of a mouthful when you have like
super important vaccines.
Yes.
Actually.
So HPV.
And why are we talking about them now, actually, out of curiosity?
We're talking about them now because vaccines are important.
I quizzed you. I'm so sorry. So no, we're talking about them today because we're doing the adolescent.
This is our adolescent week, and really just our introduction to adolescence because it's a real big subject.
Yeah, we're going to talk a lot about
the vaccines that are a little more focused,
right? On and that you typically get in adolescence age, like they come around that 11-year-old well-child check.
So HPV is easier to say than human papillomavirus, which is what it actually is. It is a virus that affects only humans and has 200 subtypes.
Yeah, that's so much.
It is much, and it's the virus that causes warts anywhere on your body.
However, some of the strains, and particularly the ones that we worry about the most, and that the HPV vaccine is really guided toward, are the ones that cause cancer. And they typically cause things like cervical cancer, throat cancers, penile cancers.
Vulvar and vaginal. It's hard to say that word too today, apparently. And HPV is the most commonly sexually transmitted infection. Like most sexually transmitted infections, the peak prevalence of the infection is between the age of 15 to 25 years old.
In most Western countries, at least.
That's true.
Yeah. And there are more than 40 HPV types that infect the entire lower genital tract.
That's a lot to pile on in there.
So there's 200 types, 40 that just are there.
Just focus, a special focus.
But it's estimated that almost all sexually active individuals will acquire HPV at one time or one point in their life.
It's just going to happen. And most of the time you're exposed to it, it's transient and your body deals with it, just kind of like warts anywhere else in your body, and you move on. But then for some people, that's not the case.
Yeah, and warts on other parts of your body, like we estimate they last like 2 years, right? It's not like they go away fast.
I mean, up to 6 years. Like the average lifespan is 6 years for most warts if you don't mess with them at all.
If you don't mess with them at all. And so like at least that long. And so you're looking at a long time for these, especially in that area. But
so interestingly, it used to be that scientists and doctors believe that cervical cancer was caused by the herpes simplex virus, type 2.
It's the one that causes like fever blisters and blisters places.
But after lots of testing, they realized, no, there was this other virus that we had to isolate, and that was actually the cause of cervical cancer. And that was found out to be primarily HPV subtypes 16 and 18.
And so they, like any good piece, and especially when you realize that the burden of cervical cancer, penile cancer, throat cancer from HPV was actually really a large burden. Like it was one of the most common reasons for abnormal paps, those types of things for those. And so they're like, we need to make a vaccine for this.
We need to stop this happening, right?
And this is really the first cancer vaccine.
It is the first cancer vaccine. It's a generalized cancer vaccine as opposed to individually. And actually it's the oldest, so it is the first.
Yeah.
Yeah, you go. Okay. So, there were lots of years of studies. I mean, 1983 is where Harold Zerhausen, I probably said that really badly, but because he's German, I don't speak German, but he's the one that isolated, the HPV vaccine or HPV subtypes that cause cancer and started the whole process of let's try to make a vaccine to help.
And he purposely picked 16 and 18 because they are the most virulent. So they were the ones that really caused a large portion.
It's interesting to say virus is the most virulent.
Oh, that's true.
It's the worst virus part.
It is the first viral particles or viral subtypes.
Yes, yeah, go. So 2 vaccines were initially available. 2006, FDA approved Gardasil 4, so it had 4 strains. And in 2009, they approved Gardasil 4 for boys, because initially it was just for girls. And then Cervarix was also a vaccine developed for just girls.
Right. And then in 2009, that was in 2009. So although this vaccine is no longer offered in the United States, because it actually went to then Gardasil 9, right? So like they added on some subtypes. And again, this is one of the things that we do with vaccines. Like, you have this first part where you're like, okay, these are the worst strains. We really want to focus our vaccine on these. But these also cause it. It's like when we talked about the pneumococcal vaccine, right? Like the types they hit first that they really wanted in the vaccines were the ones that were the most virulent. But then we also wanted to get these other ones that were causing lots of other pneumonias and that type of thing. So the same thing happened with the human papillomavirus vaccine, where we kind of kept expanding it because there are other types that cause cancer.
Right.
And so as we identified more types causing cancer, it was easier to add those to the vaccine that had already been developed.
Right. So. And, and kind of what changed the decisions to make more subtypes was they realized that HPV was responsible for more cancers than just cervix and penile. They started to be like, wow, other parts of the body, that's what the cancer's caused by. We used to blame it on smoking, but you know what? People are smoking less, and throat and oral cancer is not going down.
Right. And that's because actually a lot of that is HPV, or human papillomavirus.
So that was in 2020 when Gardasil was approved for uses beyond cervical cancer. And prior to that time, the vaccine was only approved to 26 years old. But after the research showed like people need it later for different kinds of cancer, they expanded it to 45 years old. And so you can still get the HPV vaccine if you have not already, up to 45 years old. And we know that it decreases your risk of cancer significantly.
Right, and then because we had changes in all those things, we also had some changes in age recommendations. And I think this one's super cool because it actually identifies how effective, like this is, again, I'm nerding out a little bit.
We love that.
But like it's how effective these vaccines are, right? Like so, and what they found is that actually if we give them younger, definitely we want to give them prior to like the sexual debut, or which Dr. Foth is going to talk a lot about, but that first time they have sex. But the actual part of it that's really fascinating is that if we give it younger, they just have better antibody
protection. Their immune response is better.
Yeah, and that immune response not only is more active, but it actually lasts longer. So they are truly protected longer. And actually, even after the first one, they show a really good immune response.
Right.
And so now they sort of changed. Initially, they kind of had it with the initial vaccines, they recommended it for 3-shot series. And you had to get them 1 month, or then a month later, and then 6 months. And then as we realized that the antibody protection was better and the younger we were, they changed that recommendation. And again, this is where we do try to limit vaccines.
Right.
Like we don't need to give more if it's going to
work. We don't need to do more.
Right. And so they moved it to if you get the vaccine under the age of 15, you only need 2.
Right.
And so as long as you were getting that first dose under age 15, you only need 2 of the human papillomavirus vaccines.
But after 15, still need 3. So if you're getting it, up
in
to 45,
20s, then you need 3. Yeah, if you haven't already gotten it. A lot now in the 20s have had the HPV vaccine, which I find awesome. Because that's like us. Like
I know, because it was a vaccine that was developed right at the beginning of our career.
Yeah,
right?
absolutely.
That was very early. And it was such an impressive turnaround right from the beginning. Like as soon as the vaccine was introduced in 2003 to 2006, they could already see a decrease in the amount of cervical cancer and abnormal paps. And by 2013, the rate of HPV went down by 88%. Like in just 10 years.
Yeah, that's, and that's so cool, right? Like just the change in it completely. And we saw this.
Yeah.
Like, this was what was fascinating about it, is that like there was such a decrease that, recommendations changed on when we needed to do things. Like it was really like this fascinating thing of like young women weren't getting as many abnormal paps. Like it really was significantly effective. And we already see that this is showing also not just direct, meaning you're protecting yourself, but we're decreasing the rate of those types of HPV in the whole community. And so we are offering herd protection too. Like, so even for people who have not had the vaccine, we are offering them some protection because they're not being exposed to that type.
Right. So HPV vaccines, very safe. I mean, they have the typical vaccine reaction, which is pain at the site, swelling, redness. Your arm does not like to have things poked in it.
No.
That's just but a couple days, it's fine.
They can get like systemic reactions are much rarer, can include like fever, nausea, some dizziness, fatigue. And those tend to happen within the first couple of days, just like other vaccinations. I always kind of mention this because I've had this happen. This is the one. So I think it's because we give it to teenagers, right? And so one of the recommendations for these, both meningococcal and HPV vaccine, is that we actually watch kids a little bit longer. And it's not because we're scared they're going to get an allergic reaction or anything like that. It's actually because I feel like every time I've seen this is because kids are not drinking and eating before they come. Like they're coming into our clinic, they're just rolling out of bed as teenagers.
Or they've been at school all day and they've not eaten and drinking
and they
all
haven't
day
ate
long.
or drank all day. And so then they come in and they get 2 or 3 shots, and all of a sudden they feel like faint and dizzy. And of course that's not the shots, right? Like that's too fast for anything.
And they pass out. I mean, we've definitely all had that. The kid's like, I'm fine, walks, and then all of a sudden passes out. And you're like, apparently you were not fine. Sit and let your body accept this change for a second, this little painful shot, and then you'll be okay.
Yeah, and they're always acting tough, right? Like, like, oh, I got this. I can just go and do it. And then they fall down and faint. So what I found, and I do this now, is not just like wait a little bit, but I always make sure I have them drink and eat something before.
Yes, that's what our medical assistants always said. Have you eaten anything today? And if not, they're like, here's some crackers.
I have Gatorade. I'm like, hey, what do you want to drink?
Exactly. So please do not pass out.
Yes.
But that is really just the actual giving of a vaccine to a teenager as opposed to a specific vaccine.
And they do tend to pass out more in teenage years. It's also that fact that they're just growing a lot, changing, having the blood supply is changing, how fast it needs to go places.
Yes.
And having to go there a lot farther, a lot faster. But yes, it is not something. It is one of those ones that the reason for that, they have the recommendation for waiting a little bit after and not just jumping up and leaving.
Do they ever jump up and just leave?
They do, and like I find that parents, like for little ones, they hold them real tight, and then they try to get out as fast as possible.
But teenagers, I feel like there's always some slow motion. I don't know when they're in your office. So, talk about meningococcal next.
Yes. So meningococcus, and this is also a fascinating vaccine to me because it is such an important one. And the reason is because Neisseria meningitis, which is what this vaccine is against, is such a dangerous and deadly.
It's terrible,
bacteria.
Right, to see somebody who has meningococcal disease. It's a leading cause of bacterial meningitis in children and young adults, and its mortality rate is 15 to 20%. Even if you give antibiotics.
Yeah. And that is and part of that is because it is so fast.
It is so fast.
And that's the part that people don't really understand is how fast this illness is. It presents often with sudden onset, fever, rash, neck stiffness, decreased level of consciousness. And it quickly, and it's within 24 hours, they're in the ICU having trouble with blood pressure and dying on us. I mean, it is one of those things that is the scariest thing that I will have, I feel like I've ever seen in my practice.
Where you see a kid who just seems sleepy, maybe color's a little off, and then 8 to 10 hours later, they are not breathing.
Right. And so most children, 72%, had one of those 3 symptoms prior to it, like pain, abnormal skin color, cold hands and feet. And within 8 hours of the onset of illness. Again, that's already showing that they're having blood pressure abnormalities within 8 hours. So that's the hard part about it, is that it's just so fast that it's really hard to catch and treat. And then you have to be thinking about it. They have to get into the hospital. They have to get to the right care. Whereas we can give a vaccine,
and then they will not get it.
They won't get it.
Yes.
It's a bacteria that's kind of spread through saliva. During close or prolonged contact. It is not as contagious as things like flu, but it is very contagious when you're looking at times when you're really together.
Right.
So you're in buses on teams together.
You're on a team together, sharing drink, right? They always share the water,
right. Yeah. Or dorms.
Right.
Dorms is a really big thing, because you're all kind of sharing stuff and drinking after one another and that type of thing. So you tend to get these in those situations, which is again why they elected to actually make this vaccine an adolescent vaccine. because this is the time we see a higher rate of it when they're doing those things. It can happen though in younger ages.
It can, especially not in the U.S., not in Western countries.
Right.
It's spread easier younger.
Yeah. But this is kind of a fascinating vaccine development too.
Yes, it is. And kind of as we talked about in previous podcasts, this really shows us how scientists and public health, analyze what we're doing with vaccines, how vaccines are making an impact, how they're being received by people in terms of side effects and, effectiveness. And so the first meningococcal vaccines were polysaccharide-derived vaccines, and they were safe, well tolerated, but they didn't really work well in kids. Kids' immune system just don't grab a hold of those polysaccharide forms.
So that they didn't, not only didn't work well, they didn't last long.
Right.
So when you had to get those vaccines, it was, you had to get them again, over
Multiple
and over.
doses, which kids don't like.
No, nobody likes really.
No.
But I can say from experience, this was actually even before I was in medical school. I was a teacher in Virginia, and we had a case where, a child in the school got sick. From this, and so they had the whole school vaccinated to try to limit the continued exposure of the bacteria, and that was a terrifying experience as just a community member and a teacher, and it was just really sad.
And he was on a sports team, right?
He was on a sports team, yeah. And that's actually the other people who ended up getting it. Luckily, because he had been diagnosed, they were seen fast enough not to have the result that he had, but
he died. So the vaccines were changed to more conjugated form, just like the pneumococcal did, and they became more effective. And so the first conjugated meningococcal, it's a lot to say, was released in 2005, and that was Menveo. And then MenACWY came in 2010, and then MenACWY just came in 2021.
So yes, and again, the basis of those are really based on the subtypes of meningococcal vaccine too.
Yeah.
So and there are 4 specific subtypes of meningococcal vaccine or meningococcal bacteria, serogroups. Sorry, not
so
subtypes.
There's 4 in these vaccines.
Yeah.
And then MenB is separate.
Yeah. So A, C, and Y.
ACW
and Y are the 4 and the initial ones.
Yes.
Interestingly, that is those are the common ones that are really, really bad in sports teams and those types of things. But there is another serogroup that has a really bad kind of issue with meningococcal disease and transmission, and that's B.
Right.
And they were really looking for a long time.
Yes,
how to
ACWY, they got that figured out. They did the vaccine. It really decreased the amount of meningococcal disease. But the MenB was really challenging because that actual strain looks a lot like the human brain. So, you're trying not to attack your own cells at that point, right? But
yeah, so they had to really work hard on this one. But they finally did, and that was Trumenba. And Trumenba and Bexsero, and that came out in 2016.
Yes.
Okay.
Oh, 2014. Yeah, and they both came out the same year. I remember the presentation of it. They both were all of a sudden they both figured it out. Ta-da! Here we have 2 choices, and you're like, which one do we choose? And they're like, we don't care, just choose one.
That's right. Again, this is actually, it highlights what all the research and study that goes into vaccines, and not just making up vaccines, but should these vaccines be added to schedules?
Right.
And they really, this is not this new vaccine comes out, we're going to add it to the schedule right away. It is we're going to look at all of the cost behind it, how much it would cost to put out to everybody, how bad the disease is, how rare the disease is, and then determine is this vaccine one that we want to have and recommend for the entire country? Or do we recommend it in certain areas, right? Mm-hmm. And so this was one where ACW and Y did get recommended kind of.
They're more common strains.
They're more common strains, and so they did get recommended across the country, but MenB actually had a slightly different uptake.
Right, yeah, and MenB is not used routinely or required in a lot of the states. Each state makes their decision, but there have been times when, because we have this vaccine, a lot of lives have been saved.
Right.
So like from 2013 to 2016, 5 different college campuses experienced outbreaks of the serogroup B meningococcal disease. And a couple of these outbreaks were before the vaccine was even approved by the FDA, but they knew it was effective, it was in trials, and they're like, we got to do this to save kids' life.
Right, and one of the big ones was actually University of Oregon.
Yeah. So do you remember it? Like, I didn't live here.
So I did remember it in the sense that we heard about it, and then for a while, every kid who was going off to college was supposed to get it. And that was 7 cases of serogroup B meningococcal disease occurred at the University of Oregon in January to June of 2015, and then 1 student died from that outbreak. And so 4 other colleges all had similar outbreaks. Again, 2 to 9 students contracting illness and either death or limb amputation. So again, this bacteria is so fast and so severe, and limb amputation is actually one of the most common morbidities associated.
Because the blood supply gets cut off to part of your body, and then you can't get it back until the infection's under control.
Yeah, and so and that was the outcome for several students actually, and some of those other collegiate outbreaks. And so those were outbreaks at Princeton University, University of California, Santa Barbara, all occurred before the B vaccines were licensed, and then but they actually were able to make that vaccine available in some of those cases. So
yeah. And then, so University of Oregon and Providence College outbreaks were right after the vaccine had been approved, but it was not very widely available. But they got it on the campuses to help save, students' lives and the morbidity of losing limbs.
Right.
And, in the past, like in the example you had when you were teaching high school, right, the only response really was to have antibiotics for everybody in the whole school. And
they actually, you had to have the antibiotics. We did get got the other vaccine,
polysaccharide.
The first one,
ACWY.
and we got that one. And then we also got any kind of close contact at all got prophylactic antibiotics.
And antibiotics we talked about are not that effective once the disease starts,
right?
Because it travels so fast. And of course, we're having more resistance to antibiotics that at some point it probably won't help as much.
Right. And so this is why this vaccine is so important, and it really does save lives. I find it interesting that it is, for MenB at least, it's still state by state.
Right.
So Oregon it's not on the required ones for Oregon.
Yeah.
Like it doesn't show up on our kind of immunization, this is what you should get, but it does in Washington.
In Washington, it's not required for schools, but it's on our vaccines for children. And so we give it pretty routinely if you're seeing the doctor on a regular basis.
But it's not for Oregon. And again, that is because there are some that they are just saying, absolutely, this is so all over the country, it is needed, we should get it right away, this should go on the...
Like HPV, against cancer. Cancer doesn't pick a state.
It doesn't pick a state, right? But other states do decide on what to think. Hep A is another one that kind of is by state.
Yeah.
But the fascinating thing about this is that, again, scientists were able to not only really effectively treat the initial strains, but then worked so hard at getting one for the most deadly one.
For sure. So the vaccine schedule is, in the US, is we give the ACWY kind of routinely around 11 years old, and then booster 16 or later. In other countries, it's given down at 2 months, or even in the US, it's given with kids who have known immunodeficiencies, like they have no spleen.
Right.
They have a hard time.
And I would say, the other thing is that if you are traveling to other countries, this is one they recommend because they have a higher burden of this disease than we do. And then there were 2 new vaccines.
Yes, and
these are so awesome.
These are ABCWY, so they're pentavalent. And their names are Penbrea and Menveo. Like, we're really running out of names. Oh my God. So like, wow. They don't really roll off the tongue very well. But Pen means 5. They have 5 strains.
And so then we're going to be able to have all 5 in one vaccine. And so right now, I guess that's being recommended for the 16-year-old.
Right, because the MenB we don't give until 16. And so it would be like a first dose of MenB or a second dose of ACWY, but you still need the other one either before or after, depending which way you go.
So again, it is really, this is two really great vaccines that are amazingly effective at keeping your adolescents healthy and making sure that they stay healthy. Yeah,
For sure.
So we also kind of talk about the second part of all of our vaccine talks are some where people are getting some information that isn't true.
Right.
And they're being exposed to that. Yeah, they really are lies. So we're just going to call them that.
Exactly.
It's true.
It's true. It's true that they're lies.
It's true that they're lies, yes. And so this one is one that we would have heard a lot about lately. It is, do pharmaceutical companies and or medical companies make a lot of money from vaccines? Is this the reason that they do it and like push all this out about vaccines? And many people in the country, and I think really believe that vaccines are these huge profit makers for pharmaceutical companies. And this is actually something you and I have talked about before, but everybody in medicine actually makes more when people are sick,
right,
than when they're well.
Okay,
right?
We're trying to get rid of our jobs, right? That's what prevention of medicine. So
that's
vaccine.
why pediatricians are so like we're literally trying to get rid of ourselves by trying to keep kids healthy. And vaccines are a huge part of how we do that.
Yes.
Pharmaceutical companies make by far much more money off of drugs to treat disease than vaccines to prevent them. And one example is like there's a hepatitis C treatment, Solvati. It's sold almost entirely in the U.S. and it costs about $10 billion a year. They make $10 billion.
That's the profit, I think. Probably. They don't make
it. Sorry, no, it's
it
not
makes
the
$10
cost.
billion for them.
It makes $10 billion a year.
Which, I mean, it's impressive because Hep C used to be fatal and now it's not.
Right.
It's
No.
treatable.
This is an amazing drug. I'm not saying that. And we don't have a vaccine for hepatitis C.
No, we don't.
We should, but we do not. So so this drug makes, $10 billion a year treating hepatitis C. Global sales of all vaccines for adults and children, so not just children, but anybody who gets a vaccine all over the world, by all pharmaceutical companies, is just $24 billion a year.
Right, and that's split over all of the different vaccine makers throughout the country. And
throughout the world,
and we don't even know, is that profit? That's just what...
it's the sales.
The sales,
them. So that's not profit.
It's not profit.
They have to make the
vaccines. Because it costs billions to make vaccines.
Yeah. So in 1 year, if you look at it, it's only 2% of the $1 trillion worldwide pharmaceutical industry.
Yes.
So 2%, they make their money, 2% of that money is vaccines.
And I think most pharmaceutical companies will tell you vaccines are public health. They feel like it's their charity work to make the world a better place, because it is basically a non-for-profit for them.
Yeah,
right?
They do not make money off of these, and in any money they make is typically right at the beginning, and then they do not make it anymore after that. Yes. Like, in fact, the longer a vaccine is on the market, like your Haemophilus influenza vaccine, your Hib vaccine has been around so long. It is not. It is no longer profitable to make at all. Right. There's only one company who will make it anymore because all of the other companies have dropped out because it's not profitable to make it. There used to be multiple
different manufacturers, but at this point they're like, why would I do it? And even with meningitis, the meningococcal we talked about, they started out with MenACWY and Menveo, and one of them had to stop making it because the supply got messed up during the pandemic, and it never made sense enough for them to go back to making it when they had a competitor already making it.
Right, and so that's what you see. These are really quite cheap to make, and once you've figured out how to make them,
that's the research and development. That's the expensive part. And then once you actually do it, they're actually quite cheep to make, and so they have a limited profit, and they're only getting a couple vaccines per kid. Exactly, it's not an ongoing chronic medicine.
No, not at all. It is if you only need 2 measles, mumps, rubella vaccines in your lifetime, right? So those are $60 a piece. And that's it. Mm-hmm. So, that's $120 on a child. And so most of that's even going to overhead. So they're just not money makers for pharmaceutical companies. Another point of comparison is if you look at the global alternative medicine market, which is a $34 billion industry a year, and only a third 1/3 of those treatments have ever been tested.
And they weren't tested before they were put in the market, most of them.
No, most of them not.
They're just tested on people.
Yeah. So I mean,
me.
like these, like they don't have to go through all the upfront testing and research and all that. They just kind of put these on the alternative medicine market, and they make $34 billion a year.
Yeah.
So again, none of these vaccines are huge profit makers for pharmaceutical companies. So then do large medical organizations like American Academy of Pediatrics and do they make money from pharmaceutical companies?
No. We are big supporters of the AAP, but the AAP is a member organization that we have chose to join because they support our interests. And our interests are taking care of children, not having fancy cars, not having nice houses. It's let's do things to help to make sure our kids are safe, right? In the whole community.
Most of the medical organizations are actually just used to support actually further education of medical professionals. Like, for example, like if you, and this is what I found really fascinating when I heard that this had been said. One, there's, two different things. Like you can say, does American Academy of Pediatrics always have their own schedule based on like pharmaceutical companies telling them what to do? And that's just not true.
No.
For the last 20 to 25 years, they've actually followed the CDC guidelines.
Right.
So ACEP makes their recommendation, and almost always, American Academy of Pediatrics just says, these are ones that were done by researchers and scientists. They make sense. They're evidence-based, and we're going to follow the same guidelines. And this is what we're recommending.
This is the first year it's changed.
And that's because they are no longer making science-based recommendations. And that is why the American Academy of Pediatrics and several of the academies came out and said, we can't follow these guidelines anymore. They're not
the best. They're best interest for children.
They are not
for our community.
And not at all. And so, and they did not make that recommendation based on money. And you can actually see that because contrary to them not being transparent, actually, if you even go just to the American Academy of Pediatric website, they have all of their financials for like the last, I don't know how many years, just online.
Right. So what they're spending money on, how they're receiving money.
Yeah, exactly. And you can just hit on the thing and say, oh, this is how much they have, like income they had over the last year, and this is what it came from and where it went. And if you look, the majority, like we said, come from fees,
members.
Actually from members. So it's membership fees from doctors who take part of that organization to make sure that their education stays up. They also, the American Academy of Pediatrics and other academies, do a really good job of offering education, like conferences, publications. They do a lot of publications that
they have amazing websites. If you've not been to the AAP website, go to it because it has really great information for parents on just every subject you can think of
around pediatrics, right? And that's what their money goes towards.
Yeah.
Like there's no hidden things, and you can actually see their financials there. They are very transparent, and again, all of these things are designed to keep pediatricians, specifically from American Academy of Pediatrics, informed and up to date on evidence-based medicines, and that is why they are now pulling away from the guidelines that are recommended by the CDC, which are no longer being evidence-based, which is really unfortunate.
Money from vaccines?
Oh my God, no.
This makes me laugh when parents ask me that, and I'm like, oh my goodness, you don't really understand what is involved in buying vaccines, storing vaccines, and how low we charge for vaccines.
Right. So this is what's fascinating to me is there's you read and they're like, oh, vaccines are being free from the government. So, and technically for Vaccines for Children program,
which the state of Washington has for all,
we are reimbursed.
Right.
But that is reimbursed. It means we have to pay for all of those first. And then we have to and then the requirements for getting those are massive. It requires a ton of data that we have to find, and then we have very specific requirements for keeping those vaccines.
Right.
They have to be stored. All of them have to be stored at a specific temperature. They can. They have to we have to have a separate generator just for our vaccine.
In case the power goes out, which I've experienced many a time.
Yeah, and then you lose thousands of dollars worth of vaccine if the temperature goes between.
And you have to have data loggers that you keep on the vaccines at all times to prove that when the power went off, the temperature didn't go down on those vaccines and ruin them. Otherwise, you have to just throw them away if
Right.
the temperature went
Yeah, and they're not, and if that happened and they figure out later, then those vaccines aren't considered valid.
Yeah.
So all of those things, like there's a lot that goes into it. And so pediatrician's office, like actually most medical offices who offer vaccines, consider it like they're just going to try to make like what they spent. They do not make money out of this. They're just trying to break even.
Right.
So that it doesn't cost them more to do what's right for their patients. I will tell you, most do it even when it does.
Right. I mean, there's definitely some small pediatric offices that are private that just don't stock vaccines. They can't afford to do it, and they have their patients go to the health department. And that's really terrible for patients to have to go to two places. And
Right.
so most of us say, we're going to figure out how to get them in our office, even though we may lose money doing it.
And that is because, again, pediatricians really just care about, and family practice doctors, or family medicine doctors, and the primary care doctors just care about keeping their patients healthy and safe.
Yes.
And that's why we, from a very evidence-based guidelines, realize that vaccines are the best way to do that. And so we put a lot of effort into it. The other part I just think is really funny is that, and there is a difference, private insurance is actually worse to a lot of extent.
And that's what my office was private, where I came from in Indiana. And with that, you have to buy the vaccines up front and store it and administer and keep those vaccines separate than the vaccines for children. And you can't let them cross or be exchanged, even though the exact same vaccines. And we bill for the cost of the vaccine and an admin fee, but not all insurances pay you back that whole cost.
Right. And it takes months and months and months, right? Like
Right.
just like anything else. So, and again, we just output that ahead of time. So these are not money makers for offices either. And I will say that like, it is funny like that we ourselves make extra money or get incentive some way for just suggesting that people get vaccinated. Like the majority, primary care doctors, just so people know, are the least paid profession of any medical profession, right? Like we get paid the worst out of everyone.
But we still do it anyway because we love it.
Because that's who we are, and that's what we love doing, right? But the fact that, and then most of us now, or a lot of us, are salaried. And so our salary is the same, whether we see a bunch of well visits and offer vaccines, or a bunch of sick visits and see sick kids all day. Like, it doesn't change for us.
Right.
And so, there's no incentive to give vaccines. Our incentive to give vaccines is based on trying to keep your children healthy. And for me, that is a really big incentive. Like, that is the whole reason I'm in pediatrics, is that I want to keep kids happy and healthy. And I get a little teary, but anyway, if I ever see one of my children that I take care of, and I consider them my children too,
yes,
get hurt or die from a vaccine preventable disease, it will be incredibly hard for me.
It won't be.
So that is really the reason that we do this.
Right.
It's not because we make money off of it. It's not because our organizations make money off of it. It's not because pharmaceutical companies make out of it. This is actually one of the things that it is the altruism of medicine.
Right. And we say that these are vaccine myths, but again, this is vaccine lies. So start using the terms that explain it the best.
Yes. What is being put out there about these people making, or about any of us making money off vaccine is a lie.
Yeah.
So, okay. With that, we hope this information helps you keep your children healthy, happy, and safe.
Yes.
And
I'm Dr. Joanne Smith.
And I'm Dr. Karina Hankins. And this is A Pod Full of Pediatrics.